I want to ask you about your thoughts on the IMforte study. This is going to be first-line potential change in practice for our patients that have extensive stage disease. What are your thoughts about it?
So in small cell lung cancer, our ability to help our patients is really driven by our ability to control disease. It's a very aggressive tumor. And so in the IMforte study, we combine platinum-based chemotherapy with etoposide with immunotherapy, which has been the standard of care. But a little bit of a twist. When we used to switch just to atezolizumab by itself, now we're adding lurbinectedin, which is a novel chemotherapeutic agent which has been approved in the refractory setting. And we've seen with the use of maintenance lurbinectedin a reduction in overall death of 27% in the study, which is quite substantial and meaningful for our patients. It's improving quality of life, improving duration of life, improving progression-free survival. And so I think this is going to be something that's part of our therapeutic armamentarium, given that we utilize these agents independently across lines, but potentially introducing Lurbi earlier in combination with atezolizumab, we're getting more patients potential long-term benefit as we see on the study.
Yeah, I think you summarized it really well. Really excited. It's always a win when we have new options, new potential options that are practice changing potentially for patients in extensive stage small cell lung cancer, a very aggressive type of disease. Another question for you, when we're talking about maybe adverse events and then patients no longer get that chemo break, right? What do you think of that and quality of life?
Yeah, I think in the extensive stage setting, the metastatic setting, we want to maximize quantity of life and we want to maximize quality of life as well. And I think the balance favors quality of life. I think when we're thinking about these maintenance strategies and combination strategies, we should be well aware it's okay to dose reduce. It's okay to give the patients a break. It's okay maybe to skip a cycle so they can go on the trip and go see their family and be in their best health and then resume treatment afterwards. And so I think we want to get ahead of the toxicities, asking the patients, asking the caregivers how they're feeling. Many of the toxicities we see with this regimen are related to blood counts. Yeah. And so just making sure you're doing those laboratory checks. This isn't a regimen I'd give and then see the patient 3 weeks later. I'm going to see the patient at least after cycle 1.